This is John Berry with the Office of Community Living. And this meeting is being recorded. We are here on October 26th already, my goodness. And for the private duty nursing, one of a series of meetings. And my role is to help facilitate the discussion. So I'll talk about that piece of it. Again, with recording, please be aware of not sharing PHI, which is protected health information, or PII, personally identifying information that you don't want shared in public. This is recorded, so the link to the recording will go on our website. Therefore, it will be out there in the public. We are, and part of my role here is to help manage what we call the speakers queue. And we are also using the chat. So there will be, there's a whole team of very skilled people, knowledgeable people who will be, I think, responding to some questions and comments in the chat. Others, I believe Candace or others will call out and speak to. And also at times we will be asking for people to ask questions or give comments verbally, and we will ask for names for the queue. And what you can do is use that little hand icon at the bottom, click it, raise your hand. To the best of my ability, I will call those in order. And to the extent we have anyone who's on the phone only, I see one phone number ending in 98. I'm not sure who that is. You can get the slides for this meeting. There's a link for that. If you're listening by phone, you can press *6. And please do, if you have background noise especially, and if you're not speaking in general, you can press it to unmute and to mute yourself again. If you're on the computer using computer audio, then please be mindful of keeping yourself muted when you're not speaking. There's a link right there for online resources. With the speaker queue, I will be doing the, as I've done before, the 2-minute time limit so that we can hear from as many people as possible. And that's the purpose of it. We want to hear from everybody. So I will be giving, as respectfully as I can, a reminder at 1:45 that you have 15 seconds left. And just a general comment, these meetings have been full of passion. These are important issues. We're talking about supporting people through private duty nursing, so emotions can run high, points are strongly made. Let's please remember to keep each other in mind in that process with respect. So thank you. I probably missed something, Candace. As usual, you'll catch it, and I'll turn it back over to you.
Thanks so much, John. Next slide, please. And I don't think you missed anything, John, so I appreciate it. So welcome, everybody. My name is Candace Bailey. I am the HCPF Division Director within the Office of Community Living. And today we are here to, again, talk about private duty nursing rules. This is meeting number 6. It's hard to believe that we have had that many meetings, but it's really exciting because this is our meeting where we get to go through all of the feedback and all of the things that we have heard from each of you during all of these meetings. I'm really excited about this meeting. And let's go to the next slide so I don't jump ahead of myself. There we go. All right, so the purpose of these meetings, just as a reminder, we want to review the private duty nursing regulations in their entirety. We want to meet with everybody to make sure that we can collaborate and make changes as necessary to these regulations. Next slide, please. So first and foremost, I want to let you know we have a lot of department staff that are here to support this meeting and to answer questions. We have a lot of experts, which is really, really awesome. We have our clinical team experts online, our policy experts online to help with both answering questions, managing the chat, and following up as necessary. So thank you all for joining me today. And if you are not internal staff, not a HCPF staff, please go ahead and complete that attendance form that Christine put in the chat box earlier. And I'll ask her if she'll repost it just in case somebody joined later. Thank you, Christine. That just gives us an idea of who all is able to join today. It's really helpful information for us so that we can better understand where the feedback and the different perspectives are coming from. John went over the meeting guidelines, so I won't rehash that. Then we're going to go through our presentation and have time for discussion and next steps. Next slide, please. So housekeeping, again, John went through most of this, so I won't rehash too much of it. The biggest thing is please make sure that you don't disclose any PHI. Please make sure you're muted when you're not speaking, because background noise is really hard for other folks. It's just really hard to overcome that and to hear. I, in particular, have a really hard time when there's other additional noises, even being able to hear what's being said. And then, there's that home health inbox if you have additional comments, questions, things related to the rule or just related to home health in general, please reach out to that. Next slide, please. So this is our process. We started our meetings back in February and really started breaking it out by section to go through with everybody. And this is kind of the timeline. And again, there's no exact dates because we really want to make sure this is a thoughtful and not rushed process. And so we are hoping to present to the Medical Services Board in the next few months. But again, I will say this probably several times, we do not have a date set yet. It is going to be based off of where we land at the end of today as to what our next steps will be. Next slide, please. And all of these first few slides have been repeats, just so you all know. Our goals have remained the same the entirety of this process, as have been kind of our agendas and the way that we are outlining it. But just as a quick reminder, our goals are really to conduct a thorough review and update the regulations as necessary. We really want to work with stakeholders to make sure that we can get rid of outdated language, make sure things that are unclear that we can help clarify, rephrase some things, restructure them in a way that they're easier to read and easier to follow. And so those are the overarching goals for this revision. Next slide, please. Here is the review. This is just the sections of the regulations. So, and just kind of how it's outlined. And it tells you which meeting we talked about those sections in. So we've gone through each one, and today is a summary of the feedback and the changes that have been made to date. Next slide, please. So just general considerations. Oh, sorry, I skipped a slide. My apologies. So the overview, again, this is just outlining which dates we met on each of the different sections. Next slide, please. And I'm flying through these because I really want to get to the meat of the meeting. It's really important to have time for that discussion. So general considerations, keep in mind these are discussions, nothing is final. We are still gathering feedback. We are still excited about the feedback that you all are providing. And then just overarching things such as certain words like client will be changed to member throughout, things like that, that we have been talking about throughout this entire process since February. All right, next slide. New slide, yay. So today's meeting format, just to let you all know that the current draft is posted. It is on the PDN webpage, and I will ask somebody to post that link in the chat as well. So if you haven't had a chance to review it or get to it or anything, there's a link so that you have access to it. So we have been gathering feedback from every single meeting and every single email and every single phone call that we have received. And we've been putting it into this listening log that is also linked here. Thank you so much, Christine, for posting all those links. Oh, look at that. Cassandra and Christine posted the link. It's a race now. And so in that listening log, it identifies what the comment was and then whether or not we were able to incorporate that into this latest revision here. All of that is online. And we update it after every single meeting. And so hopefully you have a chance to take a look at that. So the format for the rest of these slides, what we're doing is we are actually summarizing the changes that have been made based off of feedback. And so if we heard from you all, for example, about not having the word community in the regulations, and we added that in, that's what we're going to go through section by section. And again, it's a summary because we have received, I want to say it's like 400 lines worth of feedback, which is amazing. So I can't go through all 400 lines. You guys don't have time for that. But a lot of it is very similar and has themes. And so we have summarized the feedback thus far and the changes thus far. All right, let's get started. Okay, so based on feedback, so we had a lot of discussion in our last meeting around definitions, and really, one of the main goals that we were trying to do is how do we provide clarity around a lot of things, but one in particular was around private duty nursing. What is it? Let's take a look at this definition and see if we can make it more clear and better to understand. And we heard that in trying to do that, what we actually did was make it more restrictive. And it appeared and it came across as more restrictive and where members might lose benefits, which was 100% not the intent. We really were just trying to clarify. And so based off of the feedback that we heard from you all, we have adjusted that definition and a lot of those terms to remove them so that it is not more restrictive, because that is not the goal. So I'll go through these here pretty quick, and then I will take questions based off of this slide. I have several slides and would love to take questions after each one. So just keep in mind, this is based off of our last meeting, so the most recent meeting, and the feedback that we received and the changes that we have already made based off of that feedback. So hopefully that is clear. So one of the things that we heard was around continuous and how difficult that was to define and to determine what it means. And so we said, you know what, you're right. Instead of adding clarity by using that word, we have created additional confusion and gray area. So we have removed that and the definition throughout the rule. We removed the word unpaid from the in-home and family caregiver definition. We realized that it could be a paid family caregiver. There could be a number of different ways that the family is providing support. And so the unpaid piece, I think, was a little misleading. And so we just removed that. We defined group much more generally rather than a specific number, because every individual and every situation is different. And so we didn't come to a conclusion on a specific number. And so went with a much more general term there. Medical necessity. So the definition of medical necessity that is actually used in most Medicaid benefits is what we used here and what we refer to here. And so we wanted to align that with what is used in other Medicaid benefits to make sure it is consistent. And so we utilize the program integrity definition to continue with that consistency across Medicaid benefits. We removed the term medically stable, as it, again, caused a whole lot more confusion than clarification, which is not the intent. And we said, great, that was the opposite of what we were looking to do. So let's just get rid of it. So we removed that. And a really big one that I thought about and I've been thinking about so much since the amazing meeting that we had with you all was updating the PDN definition itself. And this is where I think last month we, quite frankly, really missed the mark. And by trying to provide clarity, it really, what it did was actually restrict the definition. And so we went back to and went with the suggestion from all of you of actually utilizing the federal definition and the state statute for the PDN definition. So we have adjusted that so that it aligns and matches and uses the exact terms that can be found in the federal definition and the state statute for the regulations here for the definition of private duty nursing. So I'm really excited about that. Let's see here, utilization management. We removed that term as it is not actually used throughout the rule. So having the definition, I think, created additional confusion. And then one of the other pieces that we heard a lot about was around having the services provided in the home. We left out and community. And so we adjusted that and added and community to those. So those are the general high level big changes based off the last meeting that we have made that you will be able to see reflected in the current definitions that are posted online as the draft. Any questions or comments about those changes? And this all came directly from feedback. And so we are so grateful for you all. And if you have additional feedback on those sections, please let us know. John, I'll let you manage the queue.
Sure. So folks, this is John, and we have one hand up so far. If anyone else has a question or comment, there's two. I recognize we have one person who's on the phone only. So phone person, if you want to make a comment or ask a question, you can unmute and give us your name. Okay. Seeing none, I will take these in order. We'll start with Galia. Galia, thank you. You have 2 minutes.
Hi, this is Galia Spachalska. I'm an RN FNP and a parent nurse provider. First of all, I would like to thank you for making all the changes that we had talked about in the last meeting. But I definitely still have some more concerns. And I think one of my biggest things in reference to the concerns that I have is the definition of private duty nursing, the definition of skilled nursing tasks, and the definition of skilled nursing and skilled nursing service, particularly because it's still quite confusing. Are we saying that private duty nursing is a skilled nursing service? Because I feel like those two definitions can be combined into one. And then my other concern is that the identification of skilled nursing tasks is actually in violation of the Board of Nursing Colorado State Nurse Practice Act, which genuinely defines what nursing tasks are. And so I just worry that actually putting this in here is really quite confusing and in violation of the State Nurse Practice Act. Thank you.
Thank you, Galia. I really appreciate that. So the definition that we use for private duty nursing is taken directly from the federal definition and what is in state statute. So that one hopefully will be more in line with what folks were thinking. And obviously we can't change the federal definition. And so aligning it with that makes a lot of sense. And so we appreciate you all providing that feedback last month. So we actually since we have posted these regulations, we have received additional feedback around the definition of skilled nursing tasks. And so we are taking a look at that in particular around if we actually need to define that term or not, because I think it does create some confusion between this benefit, which is separate and it's a different benefit than long-term home health, which includes the intermittent nursing benefit. And so part of what we're hoping to do is create that clarity. And so we did receive that feedback. And so we are taking a look at the skilled nursing task definition and whether or not we need to just remove that altogether.
Okay, and then one more thing I just wanted to add, because we had quite extensive conversations when we're talking about private duty nursing.
Mm-hmm.
And it says who require more individual and continuous care.
Mm-hmm.
Again, I think that wording implicates and basically continuous means 24/7. And I would really urge the department to change continuous to continuing care or continuing, nursing care.
Mm-hmm.
Because I think that creates a more viable definition. And there's a big difference between continuing and continuous. So thank you.
Thank you very much for that feedback. I will point out that word is actually taken directly from both the federal regulation and state statute, word for word. John?
Thank you. So now we will go to Katie. Katie, thank you. You have 2 minutes.
Hi, good morning. I also wanted to echo what Galia said, just in terms of thanking the department for the changes that were made, particularly in the PDN definition, and really defining it in terms of by comparison to the home health benefit. And so we really appreciate that and sort of how you're articulating all the changes, which makes it easier. The one piece I just wanted to sort of bring up was the skilled nursing and skilled nursing service definition, and that in piece about for tasks that cannot be delegated. And just to make sure it's very clear that it's the nurse who ultimately has to make that determination, just based on our statute, which I'm happy to quote, but don't need to, and the regulations. And because it's the nurse who's ultimately responsible and it's not just task-based, right? It's a task that can be delegated and that the nurse says, this should be delegated to this delegatee based on this patient situation. And so what I would recommend is saying something like, cannot be delegated based on the nurse's judgment, or cannot be delegated and is not delegated, just to make sure that it's very clear who's ultimately responsible in making that determination.
So let me ask you this, Katie. I received, again, some feedback that came in earlier this week after we had these posted. One of the suggestions that actually came in was changing that term tasks, and I'll ask the group of this, from task to care. So, or allowed practitioner for care that cannot be delegated. Does that change anything for you? If we adjusted that word?
I think that's helpful.
Okay.
My part is not even the tasks or the care. I do think that would be beneficial. I think that cannot be delegated, just doesn't identify who's making that call. And so I would, even if you did care for care, that cannot be delegated based on the nurse's judgment. Again, where the point is to identify that it is ultimately the nurse's responsibility. It's not just that, oh, this care can or cannot in a vacuum be delegated.
Gotcha.
Do you understand that distinction?
Yep.
But I do think care makes sense. Yeah.
Okay, that's helpful. Thank you very much.
Thank you, Katie. So we'll go to Pam. Pam, thank you. You have 2 minutes.
Hey, I just had a question. When you're talking about the skilled nursing and the home health benefit versus the PDN benefit, and then you kind of throw in the word intermittent, I guess where I'm confused is none of that matches anything that's really stated in the regulation for home health benefits, nor does it match anything on your fee schedule. So is that something that's going to be clarified? Because intermittent is not mentioned on a fee schedule, and it's not mentioned that I'm aware of in the home health regulation. So we're using a term in this regulation that's not mentioned anywhere else.
I appreciate that. And I don't think we have actually utilized the term intermittent in these regulations, and I'll double check that. Intermittent was just because both a private duty nursing nurse and an intermittent nurse, they're both nurses. Using the term intermittent just helps me with explaining that they're two different benefits. But I hear you, and that is not the title of the benefit itself. Cassie?
Right.
Did you want to jump in?
Pam, if I may, what I was just going to say, under the eligibility section, what we do have is it requires skilled nursing services that exceed what can be managed with intermittent home health services. So that is where it's mentioned. And I think the point, and you can, help if fill in if this isn't helpful or making sense. But I think what we're trying to say is if there are things that are not through the home health benefit, and maybe we just take out the word intermittent and we say home health services, that this is kind of that alternative.
Right, because I know that on some of, like the letters that are going out or have gone out in the past, right, the word intermittent is used, but there's nothing on the fee schedule for a home health. Do you know what I'm saying? Like, I feel like we're still a little gray on what the difference between skilled nursing, like even with this definition, right? Because you're using like words and letters, and then you're using words and regulation. So yeah, like I just, as a consumer, I'm just still kind of confused as to like what that means as far as the home health service and what that means when you're looking at the fee schedule.
Yeah, so the fee schedule is pretty, there's some limited characters and things like that, so we have to keep it short and sweet. We can take a look at how that is titled there to see if we can bring some clarity, and then also we can take a look at the long-term home health regulations in the near future to make sure we can bring some clarity there as well.
Okay, that's it.
Great, thanks, Pam.
Thank you. That's all we have in the queue for now. Candace?
All right, well, if no other questions on this one, let's go to our next slide. Okay, so the revisions based off of our stakeholder meeting, which is stakeholder meeting number 4, around benefits and eligibility. So some of the things that we were able to make changes off of based off of you all's feedback, which is highly appreciated, is around the eligibility section. So reorganize the sections so that the order of them is the same across benefits. And so what we did was we wanted to make sure the flows are the same. It's easier to read when you have multiple benefits when they are ordered in the same way and they're not always different. And so we're trying to keep some consistency there. And so we moved the eligibility section before the benefit section. Another one that we heard a lot is we removed the continuous language from the eligibility section so that it now matches the federal and state statutes. The definition does still have the word continuous in it, but again, that is copied directly from the federal regulation and the state statute. We updated terminology to Medicaid to Health First Colorado under the eligibility section because within the state of Colorado, our Medicaid system is called Health First Colorado. We received some feedback that we had a lot of different terms that we used that really created a lot of confusion. And so we appreciated that and agreed that that does create confusion. And so we actually removed those terms to make sure that things are consistent and we're not using different terms to describe the same thing. So that was really helpful. We moved the reference to nurse delegation as that is up to the discretion of, sounds like the nurse or the home health agency. So we removed that because the way that we had it was a little inconsistent and hard to follow. So we got rid of that. Focused, let's see here, remove some duplicative language. It was pointed out that we had some things that were duplicated in a variety of different sections. And so we kind of tried to streamline that and remove that down. Made language around limitations much more concise. So we narrow things down there. And then the removal of the specific hospital discharge process, what we did there was in suggesting to remove this so that it is the same for how you onboard members with an agency. We added the language that speaks to the general onboarding of a member. And then in areas where there's a difference between discharging from a hospital, it's noted in those steps, but it didn't. Most individuals or many individuals are onboarded to this service, not just from a hospital. And so we wanted to make sure that we had the onboarding, the process there outlined across members. And then where there are differences or things that we need to note when it is an individual coming straight from a hospital, we noted those. So those are the high level changes that we made in the benefits and eligibility section. And I would love any comments, feedback, or questions.
Thank you, Candace. So if anyone does, you can raise your hand in the webinar. Again, the person on the phone, if you want to speak as well, you can unmute *6. Give me your name. Okay. Let's start with Katie. Katie, thank you. You have 2 minutes.
Thank you. First, just to say, again, I really appreciate the changes that were made already. I still find a couple problems with the EPSDT standard. So the first section here is for all members, including people under 21. And I just have concerns about like deterioration of a chronic condition, loss of function, imminent risk to health status, risk of death. None of those things are requirements for kids under 21 because EPSDT covers services that maintain function and address pain. Also later on in the under 21 section, in the B part on the next page, there's this ensuring member safety. And again, it's just that's sort of a more limiting of what EPSDT would require. EPSDT, based on the Medicaid Act, correct or ameliorate defects in physical and mental illness. So I think that those things should be removed. But I also think for the under 21, or excuse me, the over 21, the non-EPSDT folks, I really have a problem with this addition of sustaining life. Because pain mitigation or bed sores or things like that could require more continuous and more individual services is not about sustaining life, but should still be covered under this benefit. And then again, just the A, B, C, and D, and E underneath the over 21 folks, it just seems like there's these additional things of multi-step processes and it's just more, it feels again that it's limiting beyond the more continuous than what we already provide under the home health benefit. And I just don't think that those are necessary. And then the last piece is just similarly with the EPSDT folks for the B, the members under age 20. I don't think that EPSDT doesn't require a combination of tech dependence and or comorbidities. It's just a need for a nurse on a more continuous basis. So again, I would remove that and basically just say if it's medically necessary. Thanks.
Thank you very much. And the intent there is not to say it has to be tech dependence. And I think it's just meant to clarify that it can be, but I hear you and I appreciate that feedback.
Thank you, John, again. So Eliza, if you accidentally lowered your hand, please raise it again. We'll put you in the queue. Galia, go ahead, please. You have 2 minutes.
Um, Thank you. I just wanted to I have some additional comments as well. And that is that I definitely feel like private duty nursing should encompass the skilled nursing definition. I also have huge concerns about talking about deterioration of a chronic condition, loss of function, imminent risk, because again, it is in violation of federal EPSDT law because a lot of our kids are not going to die. But they do require a certain level of skilled nursing services that can be provided in the home that would keep them out of the hospital. I also feel that there's a lot of questions about the PDN service being considered supplemental to the care because it's not. Our kids receive PDN services because it's medically necessary. And the severity of a member's clinical condition shouldn't even be there. Like that is a decision that is done by a physician that is covered under medical necessity with federal EPSDT law. And the severity of the member's clinical condition should not make the service medically necessary. And I believe that that should totally be taken out because it's not really appropriate for that to be in there. I do appreciate all of the other changes that the department was able to make. But I
Galia,
think
you have 15
putting on
seconds.
there
Thank
that a
you.
member's need for
Galia?
skilled nursing is based solely on
15 seconds, Galia. Thank you.
okay, I will comment again. Thank you so much.
Thank you, Galia. I really appreciate that. And it's comments and feedback like this where there's specific words or phrasing that is coming across with the incorrect meaning than what we intended. And so I hear you with the supplemental phrasing and then, many of the other points as well. That one's an easy one to point out. So I appreciate that very much. Other comments or feedback on this particular section? That's
Folks, I
John's
can
job.
see you.
He's supposed to ask, not me. Sorry, John.
No, you can raise your hand. I know Eliza was in the queue before. I think perhaps changed her mind. Looks like someone else was there and went away. Anyone else for the queue?
So I see Eliza does have a comment in here about reviewing with the hospitals, and we can certainly chat with them. A discharge from a hospital is never solely on, there are requirements the hospital has to meet in order to safely discharge a member that are far beyond just private duty nursing. And so that's why we didn't want to have a whole section, but I hear your point and we can certainly check in with them.
Looks like that's all we have for right now, Candace.
All right, well, let's move on to the next slide then. You guys are cooking right through it today. All right. Galia, I think, wants to add more on the last slide.
Thank you,
Thanks,
Galia.
Candace. Sorry, I just have two additional comments to the last slide, and I'm not sure. Are you guys on 8.54.2.B?
Yeah, 2 through 4. So yeah, point B would be in there.
So the criteria for approval of PDN services outlines all of the documentation that's needed, but it's not stated that it's to be provided by the home health agency. And then it also says a member's need for skilled nursing care, again, and it's based solely on their unique condition. Again, there's that question of skilled nursing care being the home health care benefit or the private duty nursing benefit. And then I think, again, the confusion of pediatric, EPSDT, and then adult. I just worry that this is, again, getting kind of really questionable about what we're talking about and what it encompasses. Thank you.
Thank you for that feedback, Galia. I hear you in that by using that term, the skilled nursing, it does create that confusion between the two different benefits. And so I appreciate that. And we'll see what we can do there. And the submission of the records, that's helpful. Thank you very much.
And then also,
you,
as
Kate.
far as the members need for base solely,
Uh-huh.
it should also have medically necessary
Mm.
ordered by a physician in there as well in that definition.
Gotcha. That's helpful. Thank you.
Thank you. Katie, you're up next. You have 2 minutes. Thanks.
Hi, sorry, I didn't realize this section was 2, 3, and 4. So in that number 4, the benefit limitations, and this I think is the comment that I feel most strongly about, is the 85404C. When a service can be safely and effectively performed or self-administered without the direct intervention of a registered nurse or licensed practical nurse, the service is not considered a nursing service. Fully disagree. I think this is illegal. And the reason I think it's illegal is because this needs to refer to the Nurse Practice Act. Like what we were talking about before, it is the nurse who ultimately decides. So here it's unclear who is deciding it can be safely and effectively performed. Just because I think I can clean a G-tube doesn't mean that that is no longer a nursing service. It's still a nursing service, and it has to refer back to the Nurse Practice Act. It has to refer back to the regulations. And again, if a service can be delegated but isn't, because the nurse says, you know what, mom, you're not quite ready to do this, or you know what, mom, your daughter is sort of stressed out and I don't think you should do this right now, it's still a nursing service. And that it's completely up to the nurse. This has to refer back to the law. And I feel really strongly that this should not be in here and it needs to be changed or removed. Thanks.
Yeah, I appreciate that. Thank you, Katie. And we can certainly, and we are actually working directly with Dora on these regulations. And so as far as where there might be some additional suggestions around how we can rephrase that, and maybe referencing the law to your point, yeah, thank you.
Thank you. Erica, you're up next. You have 2 minutes. Thanks.
Oh, Erica, I think you're still muted.
Oh, thank you. I will unmute myself. Sorry about that. Hey, everyone. Is it
Oh, Erica, I cannot hear you. I'm so sorry. You are breaking up so much. I cannot understand you.
okay? Maybe I'll change locations and come back.
Okay. That I could hear that just fine. Sorry.
Okay. Well, let's try that.
Okay.
I wanted to comment on section 8.540.3B. Is that in this division also? Okay.
Yes.
So mine is the added language identified by HCPF and used by the URC. And my comment would be if that medical necessity criteria identified by you all and used by the URC isn't provided, I guess it's a question, isn't provided to the public, I guess is or is it not? And then the second part of that question would be like, if it's not, is that considered an underground regulation and, trying to basically have us not be aware of what, like as a home health agency, then we would not be aware of like what that medical necessity criteria is that was developed by you all. So I guess I would just urge that information is a little bit more transparent if it's not already planned to be.
Yeah, and I appreciate that. It is certainly not an underground regulation. That is not the intent. The intent here was to make it clear that we provide guidance to the utilization management contractor, the URC. And I hear you that perhaps, and I see the comments coming in that maybe we just need to refer to the medical necessity criteria or medical necessity in regulations. And so that might be an area where we tried to add some clarity and it didn't work. So
that would be helpful, I think, just because then when you read that, your mind starts to go, well, what is that medical necessity criteria and where is it? So if it's referring back to another section, if you guys could clarify that would be super helpful. Thank you. As just so there's not some question as if there's another magical checklist that, we should be trying to track down.
That's fair. Thank you very much.
No problem. Thank you.
Thank you. Looks like we have one more in the queue. Gail, you're up next. You have 2 minutes. Thank you.
I think it's Galia.
Galia, I apologize.
Thanks. I just wanted to express concern. Are we on 8.540.4.D?
Yeah, so we are doing 8.540.2 through 4. So the whole sections in benefits and eligibility.
I genuinely believe that this entire thing needs to be deleted. Honestly, it's offensive. It's really absolutely ridiculous that you should actually outline these limitations to the PDN benefit, because there's no reason that any patient should be receiving care on the list that you gave. And I just feel like it's unnecessary, and it's unbelievable that you would actually put this into a code of regulations. Like, I've never seen anybody not receive PDN because they genuinely needed it. And I just really worry that this is going to be interpreted in other ways. And, they're like my child, for instance, like I have to be able to have PDN care for him in order to attend school. But in order for him to even do Community Connector, he has to have, he has to have PDN in order to access those services. I just really worry that the wording is not only offensive, but it's really not applicable to the population that we're addressing, and it's totally out of context. Thank you.
Thank you for that feedback, Galia. We have limitations in all of our regulations, and so it is quite common to have those outlined. It is the way that the health department is able to survey and hold providers that are doing things incorrectly or inappropriately or, quite frankly, illegally. It's a way for them to hold them accountable. But we will take a look at this wording to revise it and make sure that it does not come across as offensive. And perhaps we need to delete some of it too.
Oops, that's all we have in the queue for now, Candace.
Great. All right, let's move on to the next section here. We are on, I have to go to the next slide. Okay, so this is from meeting number 3. So it was around the provider requirements. It is section 8.540.5. And so all of those that fall within those numbers. Here are some general things that we were able to make changes based off of feedback. Again, we wanted to kept the language about agency eligibility requirements to match the home health rule. And this is really to align the language and the requirements and making sure the agency requirements match across so that you don't have different requirements based off of, different services. We want agencies to understand their requirements. Additional language was added around the purposeful activity of awake hours and the nurse. And this is really just making sure it's clear that nurse sleep time is not reimbursed under private duty nursing. It has to be awake and active. Then we added some language here around the max number of hours a day that a nurse can work. We actually align these directly with the DORA regulations there. Clarified that a designated case coordinator is responsible for the management of the PDN service outside of hospital discharge as well. And then clarified some language in regards to home health agency's role in coordinating and communicating with a physician or a loud practitioner about the member's change of condition. We had some of that language in there that made it sound like the agencies were responsible for the way that a physician communicated with them or interacted with them, which was not the intent. And so we adjusted some of that language there. Questions on the changes that were made, or perhaps any other things that you have noticed in that section?
Folks, if you do, you can raise your hand. We have one so far in the queue. And as always, the phone person, you can unmute, give me your name. Okay, let's start with Galia. You have 2 minutes. Thank you.
Thank you again for outlining all of this. I think it's very, very helpful. I guess in reference to PDN services, it's pretty self-explanatory in reference to the home health agencies. But I know that when a child receives PDN services, that there's also a part of federal statutes that also states that the state is responsible for the nursing staffing levels or providing the staffing to provide those services. And due to current staffing shortages, is there a way to integrate that? Because there's a lot of families that are not receiving PDN services, even though they're approved for it, purely because there's no nurses to provide them. And is this part of that, or would that be a separate thing, or is that something that HCPF is starting to discuss? I just think it's a huge issue. Like, I haven't had a nurse in almost 3 years post-pandemic, and I genuinely believe that there is a federal statute that states that the state has to be held responsible for that. And so how do we incorporate that into this rule so that we can actually get more staffing for our children? Thank you.
I appreciate that, Galia. And staffing in the workforce is hard. It is an issue that everybody is struggling with nationally. We have over $250 million that we are utilizing from ARPA funds to work on a number of our workforce issues and trying to figure out how can we help this entire industry. So that's not a solution. We don't have the magic solution. Nobody does, unfortunately. But not only are we working on that, I know that other state agencies, DORA in particular, there's some statutes that waived the fees that are for renewal of a nursing license and renewal of a CNA certification. So there's a lot of things at the state level that are being done to try to help with that. But as of, for that rule that you're referencing, that is actually specific to skilled nursing facilities. But that is not something that we have outlined in any regulation at this time.
Thank you. Katie, you are up next. You have 2 minutes. Thanks.
Thank you. I just had a couple quick things. The first was about some things that were taken out. It looks like one part was cultural competence was removed, and it makes it seem like we don't value cultural competence and that there's no training required for people at home health agencies to have cultural competence. So I was curious about that. And then there were 2 parts that were taken out that has to do with that it's the home health agency's responsibility to submit a PAR or to submit the application for PDN. Those were removed between, it's at 3, B, and C. And I don't believe, and I'd be very interested to hear from the people who actually work at home health agencies about this, but I don't think it's identified anywhere in this draft rule who's ultimately responsible for submitting those. So I was curious, why those were taken out. And then separately, the new addition of that purposeful activity, I'm a little bit concerned just because I don't know what a purposeful activity is. And I'm wondering, does observation count, right? I'm not doing anything, or it doesn't look like I'm doing anything, but I'm doing observation. Does that count? And I was also just curious about the addition of that sentence, staff must be physically able and mentally alert to carry out the duties. Feels like if the staff member wasn't, wouldn't the home health agency fire that person? Wouldn't that be against the policies of the home health agency, State Practice Act and professional standards of practice that are referenced above? So I just wasn't sure about the sort of reason behind that addition.
Yeah, sure. Thank you, Katie. I'll start with the first one. And hopefully I hit them all. So if I miss one, let me know. The first one around the cultural competency, that's actually outlined in training specific to the individual. So that's where that is, where that information was moved to. So it's training specific to each individual, and the agencies are required to do that.
Do you mean it's in home health agency policy? What do you mean by the training of the individual? Yeah.
Training specific to the member, so specific to the individual. So each agency is required to train their staff that are providing services in accordance to the needs of that specific individual, which would include their cultural competency and things like that. So that is required. Submission of the PARs, that is in the PAR section. And I think that was part of the feedback that we received, that there was duplication around that. So I hear you around that if the staff is not able to perform the duties, that the home health agency would fire them. Unfortunately, that is not how things always go. I've worked in the system long enough to see the few bad actors that exist, and without having these very clear rules and regulations that provide the teeth for our health department, those things are necessary to outline in your rules. So while they seem very straightforward that it would go against their own policies, if it's not in our regulations as an additional form of stating it, it makes things a lot harder. So yes, I agree, they should fire that person if they are not performing it the way that they should, but that doesn't always occur. So hopefully that gets at all the points there.
Yeah, the only other one was just confusion about what a purposeful activity is and would be, and does that include observation, and how do we prove what a purposeful activity is? Just because it seems like a sort of a new phrasing and a new term that's not defined.
Okay. Let me take that one back to the team. I'm looking for it in the rules because I'm scrolling through the rules and the presentation at the same time here. So let us take that back and see if we can't either rephrase, delete, or whatever, because it is a little bit confusing. So thank you for that feedback.
Thanks, everyone. So that's all we have for now in the queue, Candace.
Great. Let's go on to our next slide here. Okay, so this is from meetings 1 and 2, which happened a very long time ago, all the way back in February and April, I believe. But we started with prior authorization, URC, and reimbursement sections because those were the areas where things really were the most confusing and where there were a lot of questions and the most feedback. And so we started there to kind of, okay, where do we need to dig in here and then move on? And so based off of feedback from those meetings, what we did was we actually removed the suggested documentation list. It was too difficult and it's too individualized for members, and everybody's different and you can't list everything. And there's just always those other what if things. And it was also clear that having that list made it seem like if you had 3 things in there that those were always required, and it added a lot of confusion. And so we removed that. And what we're going to do is create a supplementary documentation guideline and frequently asked question, which is under development, so that it's a lot easier. And then as things fluctuate and that kind of stuff. So we are going to create additional guideline around those documentation pieces, separate and outside of the rules. And then added some additional information on how more than one home health agency can provide private duty nursing services to one member. So to get at the staffing piece, we've seen this a lot where we have one agency that can staff 8 hours, but the member is actually approved for 16. And then we have a separate agency that has another nurse that also is available for 8 hours, but then you have 2 different home health agencies in there, and that actually is allowed and appropriate. And so we added some information in there around how that can work. Let's see here. We removed the reference to the contract and added in utilization review timelines and who is responsible for each step. So that was some feedback that we received about wanting that clarification. And then expanded language around, added some clarifying verbiage around the group rate there as well. And this is, again, sections 8.540.6 and 7. Questions, comments, or feedback there for us?
Folks, if you do, you can raise your hand in the webinar, or on the phone, you can unmute your phone. We have 2 so far. Anyone else? Okay, Galia, you're up first. Thank you. You have 2 minutes.
Hi, I just wanted to talk about the prior authorization procedures. And I know that we had discussed this in the past. But again, a lot of our families, due to staffing shortages, are not able to get nurses in one agency or another. So I'm really, really glad that the addition is made that, we're able to have it in two home health agencies. So the biggest problem that I see is that it's not identified in any of this, stating that the PAR follows the patient, meaning as of right now, if I wanted to change agencies to another home health agencies because they have the ability to provide more staffing for me, I'm not able to move to another agency without first being discharged from our home health agency and then readmitted, and then a brand new PAR authorization process to be submitted. And then I have to wait to see if the PDN hours are actually approved. And so I'm just wondering, we had talked about this in the past, so I wanted to make sure that it's definitely included into this rules and regulations, because a lot of our families are really suffering. And I know for a fact that, like, I can't change agencies, even though I haven't had staffing in 3 years, because I risk my PAR not being approved. Thank you.
Thank you, Galia. That's a really great point. And we are working on that process within the system itself to figure out how it can work. So I don't have the exact language here because I'm not sure exactly how it works within the system. It's because we have to work through 2 systems, but I hear you, and it is 100% something that we are working on.
I just think that this is a really great opportunity for that to happen, since it happens on
Agreed.
all the other services, like physical therapy, occupation therapy, speech therapy. And so the wording is already in statute for those areas. Can we add that to this PAR regulation so that it is solidified in statute?
That's a really great point. We can take a look at the other benefits and see kind of how the language is there and see what we can add here. This isn't statute, this is just regulations. So I will just make that point of distinction there. But yeah, I completely agree. It's a really great opportunity to make that adjustment. And we are certainly looking into that and figuring all that out right now.
Thanks. So Katie, you're up next. You have 2 minutes. Thanks.
Thank you. I have 2 significant ones and then 1 smaller one. The first one is this reference to the PDN tool. That's not identified. It's not provided in the rule, which is against the Administrative Procedures Act. You can't just refer to things without providing them or providing them, in a public way. And I don't know if this refers to the pediatric acuity tool, which I'm sure doesn't apply to adults over 21. So that part, I just think isn't going to fly just with the APA's requirements, because I don't believe it's identified and I can't find it.
It is available, and I'll make sure that it's easily accessible on the private duty nursing webpage. It is a specific private duty nursing acuity tool that exists, and that has always been required, and it continues to be required. And we will make sure that it is easily accessible, but it is 100% accessible and out on the webpage right now.
Okay, and I would argue that the APA requires it to be put into the rule then.
It doesn't. We're actually not allowed to put specific tools into our regulations. I've done this a lot of times with tools. We can call them out, but we don't do attachments or addendums like that. We've been told multiple times. We've been told multiple times to remove them.
All right, I don't know what that is, so I would love to see that and certainly make it as accessible as possible. The other part is this concept of providers should only request services allowed or covered under the PDN benefit. I think that providers here means the home health agencies. I think this should be that the home health agency should only request PDN services consistent with the plan of care. I don't think that we should put and again, I'd love to hear from home health agency staff, but I don't think we should put the onus on them about what is to know what's allowed or covered. And I also think it goes against the sort of just ask idea of EPSDT, which is EPSDT covers a lot of stuff, just ask and see if it's covered. And so I think I disagree with putting this in there and sort of putting the onus on providers to know what to ask for instead of just asking for what is consistent with the plan of care, just asking for what the allowed practitioner has said that person needs.
Right.
And then the last part, just a smaller piece, is that there's several mentions in this section to providers. And I think that means the home health agency, but it makes it a little bit unclear if we're talking about practitioners or different providers. So I would clarify that. And then the last one is there is a timeline in here that says within 1 business day, but I think the URC has to do something within 1 business day, but it doesn't say within 1 business day of what. And I can find that and give you the citation, but I just was wondering, like, wait, what is one day of what?
Yeah, if you could find that, that would be helpful.
It's 85406D, utilization review number 7. Written notification of all PAR denials, including a member's appeal rights, will be issued within 1 business day to the member or member's designated rep and the submitting provider. It just doesn't indicate what one
I
business
see.
day of what.
Okay, the determination. So, but I understand your point there. Yeah, that's helpful. Thank you. Okay.
So is there a limit? Is there a timeline on when the URC needs to make the determination? Because otherwise, that 1 business day isn't helpful.
Yeah.
Number 5, 10 working days.
Yes.
Yes, got it. Okay, thank you. Appreciate
Yes, of course. Thank you. And thank you for all of that feedback. I appreciate that.
Thanks. We have one more. Galia, you're up next. You have 2 minutes.
Hi, thank you so much. I genuinely really appreciate this revisions that you guys have been working on, because it genuinely shows that our input and feedback and everything is really taken into account. But I just worry with some of the way that this is categorized in regulation in reference to pediatrics and adults, and then mixing them together and then doing it in these categories. I think it would be helpful in order to have one regulation for pediatrics from beginning to end, and then another one for adults from beginning to end, incorporating all of these. And while that might be duplication, I also feel like it would really be able to encompass federal EPSDT guidelines a lot more succinctly. And I worry that a lot of these definitions, clarifications, and processes would be then applied to pediatrics inappropriately. So I'm wondering if HCPF is willing to do that, so that this process is more seamless and it's identified accurately. Thank you.
Thank you for that feedback, Galia. You know, and it is something that we have talked a lot about. And ultimately, none of our regulations really split it, not none of them, because we do have programs that are specifically just for children. But as a whole, where we serve both pediatrics and adults for one particular program, we have it lumped together because EPSDT does trump all of that. And so there aren't enough of a difference here that it warranted to completely break it apart, but I'm happy to take that back and have that conversation again.
Thank you. Candace, looks like we're covered the queue for now.
Great. Any other questions? So our next slide is actually our next step slide. So those were the summaries from the feedback that we received and the changes that were made. Again, those are just summaries. There are a lot more changes that were made based off of your feedback. It has been incredibly extensive. We really appreciate it. It's all documented in the listening log that is online. So, you know, this was intended to be our last meeting. I think what I would like to do is I would like to open it up and ask folks where you think we are. Do you think we need some more time to just review and submit additional feedback for us to look at? Do we need another meeting? Or do we go to Medical Services Board? Full disclosure, I am not ready to go to Medical Services Board next month. That's not feasible because we still have to go through all the steps and everything like that. But point being is, you know, where do you want to see this with the intent of we need these rules to go to Medical Services Board so these changes can be made. But I would really like to hear some feedback from the group on what would be the most effective for you as far as next steps for moving these regulations forward.
Thank you, Candace. So this is John. If anyone has a comment, response, thought to what Candace just asked, if you can please raise your hand, get yourself into the queue. Next steps, basically. Okay. I'm seeing one so far. Feel free to jump in if you want to add yourself. Galia, please go ahead. You have 2 minutes. Thanks.
Hi, Candace. I really appreciate you asking that question, because I think that there were still some significant concerns that were brought up at this meeting. And I would like the department to consider the input from today and schedule another meeting in 1 month so that we can finalize some of the input that we had today into a regulation that's finalized. And then we can see if there's any input based on the changes and input from today, if that still needed to be discussed in more detail, so that the stakeholder process feels more complete and we all feel comfortable moving forward. And I would really appreciate that. And if we can make that like a significant amount of time, but again, giving everybody kind of a month to kind of go through all this and kind of review what the input was on both sides and be able to come back to the table with some really good additional feedback and some time to really look at it a little bit more closer and in detail. Thank you.
That's helpful. Thank you, Galia. So the suggestion that I see from Galia and actually from Chris Russell is about another month and then kind of reconvene. And it looks like
Thank you.
Katie has her hand up.
Katie, you're up next. You have 2 minutes. Thanks.
Oh, thanks. I was just gonna say the same thing as Galia and what Chris Russell put. Just we'd love to see, the next draft and have a little bit more time to process and have another meeting like this one, because I just find them very helpful. Thank you.
Great. Other folks want to chime in on kind of what would be the most helpful? Cassie wants to chime in. She has some thoughts on what would be most helpful for her.
Well, I just want to keep in mind, it's going to take us, we're going to have to do some convening. I think we got some good feedback where we need to have some internal discussion. We have a draft that we'll have to put together, making sure we give you plenty of time. And I just want to be cognizant that we are heading into the holiday season. So just as we're thinking about that, does it make more sense? I don't want to delay this, but how do we want to think about that? Do we need a month and a half? Do we need 2? Should we just say, forget this and wait till January? Because I don't want to push it, but just being cognizant of the amount of time we will need to rework these changes. And then the holidays, which always gets tricky.
Yeah, thank you, Cassie. So that is exactly the point I want to make around the holidays. Is we do have both Thanksgiving and then the other holidays that come up in December. I would almost recommend doing that last week of November. Folks, HCPF may all be scowling at me right now and going off camera so they could scowl even more at me. But I hesitate to wait till January. I also don't think the beginning of December is feasible for the HCPF staff, given the Joint Budget Committee schedule that has been released. And so that's our time is consumed and we have to be ready to answer those Joint Budget Committee questions. But I would like to have the opportunity to go through. I think you all have a draft. And so the changes, while the feedback from today will incorporate additional changes, that you can still take a chance to digest what is already out there. And I think Cassandra provided where the PDN tool is already out there. So I'd like to propose maybe we look at that last week of November that is after the Thanksgiving holiday and then before everything kicks off in December. So any other feedback on whether or not that is enough time for you all? There is a lot of comments going on right now about the tool itself. I just want to make sure folks realize that I'm also asking a separate question. Do you think that is enough time for you all to digest the information that's out there and provide additional feedback? Not
Sorry,
hearing any.
Is the
Go ahead.
question providing additional feedback on this current draft or after we get another version based on the feedback we provided?
I mean, really and truly, this draft is going to have the most of the information. There will likely be, there will be some additional adjustments, but they're not going to be as grand in scope as this one is. And so there will be additional adjustments and we can get those out as soon as possible. But is 2 weeks enough time to look at the new draft? So Chris Russell votes for January.
I see Galia has her hand raised. Galia, go ahead, please. 2 minutes, thanks.
Honestly, Candace, I don't feel that 2 weeks is a viable timeline due to the significant kind of concerns that we had and the fact that you guys are going to have to come back to the table with a draft at least a week beforehand. And so I worry that that timeline is way too hectic and it's not enough time. So I would like to maybe say that we're at the end of October now. And I think a feasible timeline would be like the second week of December, so that it's before Christmas. And perhaps that would be an adequate timeline for HCPF.
Unfortunately, that week we are actually going to be required to present to the Joint Budget Committee. And so that timeline does not work for HCPF, that week in particular.
The first week of December.
So the potentially the first week. Let me take a look at that. Cassie, do you have the JBC schedule at hand? I can pull it up.
I didn't know we got it yet.
Oh.
And I think, yeah, to your point, that's part of the problem is we still are waiting to find out when our department presents and goes in front of the Joint Budget Committee. They're a little late in getting us that schedule. It's usually the first or second week of December. So we just aren't
second week.
Okay.
The second week of December is when we are going to be presenting. So perhaps that first week of December, maybe we can look at that week to Galia's point, because then it is still before Christmas and the other holidays, but after Thanksgiving, and provides an additional couple weeks. Yeah, so December 11th is our briefing. Okay, that's helpful. So I have a vote for the first week of December and a vote for January. I know that there are a lot of other individuals on this call, many of you who have not spoken up at all. Any other ideas? Would the first week of December work for folks? The first full week, because I do realize December starts on like a Thursday or something like that. Heather says January. Deborah says December. We need like a poll. Cassie, can you pull together a poll really quick? Are you that savvy? I am not that savvy, in case anybody's wondering.
Okay, let me see. That is asking.
I know it's on the fly too. Sorry.
Oh, and I don't know. Christine might be able to. Google has very strict restrictions on who is the host and what they can do. So.
Any other thoughts while we're working to see if that's even feasible? I realize we've kind of gone a little off kilter than normal, but it's really important. Oh, thank you, Christine. It's really important to us that we get your feedback in a way that's reasonable.
Candace, this is John. I'm even less savvy than you or Cassie or anyone, but if you identify two options verbally and say number one is this, number two is that, put a number in the chat and maybe you can collect numbers. Unless Christine is saving.
Christine put it in there. She got a poll started, so you can vote for January or December. And we have, it's moving. We've got a few votes. 3 for December, now 3 for January. You guys are going. Keep going. Keep going. We'll get this in. It's tied. Where's this poll? So if you click on thank you, Chris. So if you click on the 3 shapes at the bottom right-hand corner of your screen, there's a triangle on the top and then a square and then a circle. If you click on that, you can then, there will pull up a screen and you can pull up the one and hit polls. And then it says it's titled next meeting, and you can it's a radio button. You either click January or December and then you hit vote. And right now, January is leading by 2 votes. Thank you, Chris. Google is pretty exciting when you learn how to use some of their tools. It's very helpful. All right, we'll leave that open for another couple minutes while I wrap up. because this is very helpful for us. Again, it needs to be feasible for you all to be able to provide meaningful feedback. And so I don't want to rush it in a way that just isn't going to work. So we will figure out future engagement opportunities based off of this poll here. But while you are taking a look at things, all of the documents and recordings are available on our private duty nursing webpage. So please take a look at those. Please share those with anybody that could not participate today. And there's a variety of ways that you can submit feedback and comments. We have a Google form, which is really exciting, and hopefully somebody can put that in the chat for me. We also have our email, which is homehealth@state.co.us. You can submit feedback that way. If you could just put PDN rule comments in the subject line, that would be very helpful, so that we know exactly where to feed that to. Or if you don't like to use the email or Google form, you are more than welcome to give us a call and leave a message with your feedback and your comments. And all of those actually feed directly into our listening log. Sorry, I forgot the name of it for a hot second. They all feed directly into a listening log. Again, that listening log is posted online and kept up to date with responses and things like that. The PDN webpage is also where we will post all of the documents, including any updated drafts. You can see the current drafts, all of that there. And with that, I think things seem to have stopped. We received a total of 12 votes out of 34 folks online. And it looks like most people are voting for January, and fair enough. So that will give everybody some breathing room, give us time to thoughtfully craft those changes based off of the feedback today, and then give you plenty of time to really comb through the entirety of the regulations and the latest draft that will go out. So we will look to provide or to host an additional meeting to go through the hopefully final iteration of the draft in January. So we will work on getting that on our calendar here very shortly. It'll be on the public calendar, which is on the OCL page. Next slide, please. Next slide, please. All right. And then there, again, just on the screen, because it's easy and I like to reiterate, there is some contact information there for you with our email inbox. We have put in a variety of ways that you can submit feedback. That feedback and those forms are also online, so you can go onto our PDN webpage to provide feedback as well, or to gain access to all those different links. Thank you all so much for your time today. Again, for your ongoing engagement and feedback. It is really, really valuable. We couldn't do this without each and every one of you. And so please continue to reach out to us should you have any other comments, questions, feedback, things like that. And we will look forward to getting a new draft out to you all here in the next couple of weeks, and then provide over a month worth of time to really digest it and to dig through it and go line by line for our next meeting that we will host in January. Thank you all. I hope you have a wonderful day. Take care.